Alhamdulillah, wassalatu wassalamu ala Rasulullah sallallahu alaihi wasallam. So, respected the students, actually, this particular is lecture on the practical pathology is very easy. And if you don't hear me and the sound is not moving, please tell me. So, regarding the examination, don't worry. This is the particular thing which Hadil has already given you. It will come. I added few slides just for more understanding because the case we discussed in the PBL was related to this one. And inshallah, it's very easy basically. And even the practical examination will be very easy. Just follow what I'm telling, and inshallah, everything will be easy. Like before, I added few slides for your better understanding, and people who want to prepare more better for SMLE something, they'll get an impetus. Okay, so I just go forward. Now these are the ILOs basically, which will come in the examination. And if you do it better, inshallah, I'll give you 20 out of 20. And I hope that it's a Hadiya, Majjan and Balash. So we are going to deal with renal calculi, and we are going to deal with hydronephrosis, hydroureter, result of renal calculi most of the time. And of course, we'll try to describe some of the features of BPH, which we have discussed a case in the problem-based learning in our module. I go forward. Now, here you can see the normal adult kidney. They might ask you in the examination, how does it look like? So, here's a normal adult kidney. The capsule has been removed basically. And the pattern of fetal lobulations. You can see this fetal lobulations over here. One second. This fetal lobulations. These are the basically fetal lobulations still persist as it sometimes does. And this is basically the hilum area. Okay. In the mid left contains this is all yellowish tissue is the adipose tissue, which you can see. The lower right is a smooth surface small clear cyst over here. You can see over here this particular cyst. Such cysts either occur singly or scattered in the renal parenchyma, and it's not very uncommon in the adults. We see it very frequently, and that has to be done. Okay. Then we have again a normal adult kidney cross examination. You can see this particular area in cross section. This normal adult kidney demonstrates the lighter area, the lighter outer cortex. That is, you can see over here, the lighter outer cortex. This is the one. This area. Okay, this is the cortex basically. This area. Okay, and this is the inner medulla. Okay, the renal pyramids in which the collecting ducts coalesce basically are drained into the renal calyces and the central pelvis. Now, this is basically the renal calyces, which you can see over here. It gets disturbed in renal pathology. Okay. Now, this is what I'm focusing over here is the obstructive renal disease, obstructive uropathy for you all, and you can see over here how the obstructive uropathy in the form of calculi, the tumors, the uretropelvic stricture. You people have added this in your, when we were discussing the trigger case analysis in this area, in the renal pelvis area, okay? And even the ureter or intrinsic part, even the calculi can come over here, and this causes a very severe pain called renal colic. There's a very severe pain. Even the tumors compressing the clot, the blood clot, the stuffed papillae, and the inflammation in the ureterointrinsic is very quite common, apart from the pelvic area. When you come to the ureteric extrinsic, the extrinsic part, the pregnancy, the enlarged uterus compressing on it, and the tumors and the retroperitoneal fibrosis will cause an obstructive uropathy. And come to the bladder, we have a lot of calculi over here, tumors and functional. Functional neurogenic bladder was also one of the differential diagnosis in your trigger case analysis. I remember that. And coming into the urethra, this is basically the prostatic urethra, from where the urethra passes, and this causes compression in when there is a benign prostatic hyperplasia or hypertrophy, and the acute renal retention occurs, and even little urine comes in the form of dribbling and urgency and all such things. So you have posterior urethral strictures, tumors, especially you have this BPH, benign prostatic hyperplasia, carcinoma and prostatitis, and all these things. And if there is a compression, the back pressure will cause hydronephrosis. And we'll try to read this today. the hydronephrosis, the hydroureters which develop, thickened wall, bladder wall will occur with diverticular, you can see over here. And this bladder neck obstruction does occur, and the posterior urethral valve cause a very clear-cut obstructive uropathy. We got to remember this for all such things. Okay. We go furthermore into form the Staghorn calculus. I don't know why this is coming. Okay. Sometimes a very large calculus nearly fills the whole calyceal system. You can see over here all this thing. This is a very large hall. Staghorn calculus is a stone, basically a hajar, yani. Nearly fills the calyceal system. You can see over here also all this area. It's like the horns of a deer, you know. Uh, Nearly fills the calyceal image with extension into the calyces that gives the stag deer's horns. Hence the name called staghorn calculus. It's a horn-like stone extending into a dilated callus with a nearly unrecognizable overlying renal cortex. So the cortex is actually, when you go on and on, this will compress. This area will be compressed totally, and the renal parenchyma actually it becomes decreased. Okay, and also it's very important for filtration of the our blood. So it becomes, sometimes it becomes unrecognizable. Also in CT scan, it becomes very thin, uh, and this will cause severe hydronephrosis and pyelonephritis. So nephrectomy may be performed because the kidney is non-functional and serves only as a source of infection. So this becomes a source of infection continuously. Can you hear me? Hello?
Yes.
Yeah, okay, right. Now you can see over here, just I focus this attention for you, the staghorn in the deer, this particular area you can see over here becomes the staghorn calculus, and you can see this particular turmeric shape, and this one you can see over here in the X-rays. The staghorn calculus comes over here. Now these are all additional diagrams. I hand this over to Hadil, but the main PDF Hadil will give you, that will be, you know, for the examination. I think it's only around 22, 23 slides. That's all. So okay, and this is additional for your understanding. Okay, now this is again an important slide where you have this calcium oxalate crystals, the struvite crystals, the uric acid crystals, and cystine crystals. And you can find this in complete urine examination. We do a tahlil shamila hagal bowl. You can see such things very clearly. And you can see the even the big staghorn calculus type and a big calculus coming over here. And you break this and try to see under the microscope, it will be looking like a calcium oxide crystals, the calcium phosphate crystals, the struvite crystals, the uric acid crystals, cystines. All such things are very, very important for us. Okay. Now, actually, basically, what is happening in a very large calculus, as you have seen over here in this particular calyceal system, which is actually compresses extensions into the calyces that gives the appearance of a stag horn. But what we have read. So now this can we are going to ask you in the examination. Okay. We go furthermore, and here you can see this particular area where you can see the hydronephrosis from obstruction. So all you can see over here, sorry, but this particular area, this pelvic cancer system is being enlarged, and you can see this is compressed area, the cortex. Okay, so a very large renal calculus has been removed from here that obstructed the urinary tract, leading to all this is the hydronephrosis. I'll try to show you some diagrams such that you remember. There is a practical thing. I just want you to get a photographic image such that you remember for your whole life. So this particular obstruction causes stasis, basically stasis. I might ask you in the examination what is stasis. That is it cannot flow. يعني يمشي البول بطيء جدا يعني, and it can even stop. The obstruction and dilatation leads to infection in the form of pyelonephritis. The infection with the inflammation is characterized by pale yellow tan areas next to dilated calluses with hyperemic surface view. You can see this hyperemia over here, compressing this area and causing the hyperemic.
Doctor, there is no voice.
Those good corticomedullary demarcations.
Doctor, we can't hear you.
Can you hear me now?
Yes.
Yes.
Can you see this? Can you see the figure?
No. Sharing is stops.
Okay, 1 second. I'll just go back. How to do this? Just hold on. I think here. Okay. Stop sharing. So I'll just share again. 1 second. 1 second. Yeah. Can you see now?
No.
No? 1 second. What to do? I click this one. Okay. Can you see it now? Hello?
No.
No.
Still no? One second, just hold on. I think it'll come now. Should come. Can you see something on the screen?
Still, there's nothing.
No, not now also. I'm moving this.
There's nothing.
How come? 1 second, I'll do one thing. What do you see actually now?
I don't see anything.
1 second, just wait on. I have to join again, I think so. Can you see something now?
Yes, we can see the screen.
Yes.
Can you see now?
Yes.
Right.
Yes,
Okay.
yes.
Sorry if I don't know, some
Doctor,
disturbance. Hello.
Doctor,
Yeah.
can you repeat from hyperemia? It's a stop here. The voice stop in hyperemia.
Oh,
When
okay,
you-
right. Barakallah. Right. Okay. Can you see the screen now? Hyperemia.
Yes, yes.
Can you see this word? Okay. Hyperemic mucosal surfaces. You can see the infection with inflammation is characterized by pale yellowish tan areas next to the dilated calyces. Can you see these pale areas in the calyces? These are all the dilated calyces and the pale yellowish area. Now here you have reddish area. This is called hyperemia. Okay. Now this is actually by the compression of the calculus which causes hyperemic mucosal surfaces, and this will cause problem. And you can see over here on the upper pole, you can see something nice demarcation of the cortex in the middle. But you can see over here down this particular cortico-medullary demarcation goes off. Now, this is all due to compression, and this can cause basically, this will cause basically pyelonephritis. And keeping in view of this one, this more advanced hydronephrosis, only a thin rim, you can see only a thin rim actually, thin rim of remaining renal cortex is seen over here. And such kidney is non-functional and a source of ongoing continuous infection. It has a iltihab istimrarian. Okay, in this process, it's unilateral, then the problem originates from the uretero orifice up to the pelvis. In this case, actually the Staghorn calculus has been removed, so named because the prominent projections you can see over here of the stone into the calyces resembling deer antlers. All those deer which I showed you was present that filled up the pelvis and the pelvic calyceal system. So they are called antlers of the deer. In this process, where bilateral, then the problem originates in the bladder or urethra. Then if you have to go down, I'll try to show you one figure. When the obstructive uropathy is down, something different. The symptoms are different. As compared to the obstructive uropathy up in the area, the symptoms will be different, and even the problem will be unilateral as compared to the bilateral. And so if you come more down like the prostate, so the process will become bilateral as compared to the unilateral. Okay, and this you should remember. And of some process, and even the neoplasms will usually compress on one side, so it will become unilateral. If it isn't down there in the prostate, it becomes bilateral. Keeping in view of this one, I was telling you, okay, and the hydronephrosis with calculus at the uretero-pelvic junction is also grossly seen over here. And this particular arrow which I am showing you is actually very important to understand. And in this one, the arrow points to the culprit in this case of hydronephrosis. A ureteral calculus caught by the uretero-pelvic junction. Basically, the kidney demonstrate marked hydronephrosis, you can see, with nearly complete loss of cortex. Such kidney will be non-functional totally. If the other kidney have a sufficient function, then the renal failure will not occur. Okay, this is very important. So there is a sufficient renal reserve capacity that is possible to survive with half of the normal kidney. That is the greatness which Allah subhanahu wa ta'ala has given us. The reserve of the kidney is so important. Okay. And we go furthermore. The uretero-pelvic junction obstruction you can see over here. And here there's a scarring of the kidney from the chronic obstruction and the pyelonephritis basically. So the renal pelvis is markedly dilated. You can see over here, this particular area. This is markedly dilated. But the ureter is not indicating that the point of obstruction is the uretero-pelvic junction. Now this has to be remembered over and over again. And here you can see, again, very important thing to understand, a probably long-standing obstruction, probably congenital, at the uretero orifice, through which the metal probe can be easily passed, leads to the marked hydroureter. Now this becomes basically the hydroureter, this particular area. And you can see over here this one, and here also this one. So more examples of hydronephrosis and hydroureter, you can go to the Google and go to the images. You can see a lot of them, and even the pelviureteral junction obstruction is quite common in such cases. Okay. And keeping in view of this one, I just go forward more, and you can see over here and here again the hydroureter. And here after this we go to the prostate. Basically what we are trying to understand is the normal adult prostate weighs only 20 grams. And we had the case particularly in this week, and tomorrow we have the closing session, and my F13 and F16 people are, mashallah, all the time well prepared. The prostate is basically a retroperitoneal organ encircling the neck of the bladder. That's the problem where the acute renal retention occurs, because the prostatic urethra is basically compressed and divided into 4 biologically and anatomically zones or regions. I'll try to show you that one. The peripheral zone. Now this is very, very important for your MCQs. The central zone, the transitional zones. Okay, there are 2 zones. And the region of the anterior fibromuscular stroma. And this particular thing, if you understand, you can never forget in your future life. Okay. Keeping in view of this one, you can see this particular CZ. There's an additional diagram for you. The central zone. You can see over here. Central zone, the central zone. My dear students, can you hear me? I'm a little afraid. Sometimes you don't hear. Yeah, very good. And this is basically the seminal vesicle, from where the all the semen is being collected and thrown into this area. And we have the TZ, the transitional zone. Can you see over here? The TZ, transitional zone. And this is the peripheral zone. Now, here I'll just draw a diagram for you. If you take a cross section over here, and the prostatic urethra is like over here, okay? And through this, the urine passes. Now, what happens in BPH? I did not teach this even to my students. Maybe I was planning for tomorrow. Now, this will compress like that, like that, like that, like that, like that, and this will decrease. And here it will close off, okay? It will close off totally, sorry, close off. And here the urinary retention occurs. So please remember, BPH occurs in the central zone as compared to the peripheral zone. Peripheral zone is over here, okay? Remember, adenocarcinoma of the prostate occurs in this region and the BPH occurs in this region. I hope you understand. Adenocarcinoma, I was saying the other day, the Jomana and our people, Batul, everything. Now, you people will do the direct rectal examination, digital rectal examination, and try to feel the peripheral part. You cannot feel the central part, right? When you feel the peripheral part, this becomes stony hard, right? And you take a biopsy from this area, and the biopsy will come in the needle, and this particular area of the tissue will show you cancer. Okay, suppose this is not a cancer, only a BPH over here and here also, so you can get the enlarged glands and enlarged stroma because of fibromuscular stroma. Okay, I hope you're understanding. I'm trying to explain you the crux of the problem. So the prostate, most carcinomas arise from the peripheral zone or peripheral glands of the organ and may be palpable during the digital examination of the rectum. Any questions I will take up now? Any questions before we proceed? I want you to be a good doctor. That's why I'm teaching extra. For your examination, I'm sure you people read this PowerPoint, you'll get 20 out of 20. Some people are only, they want to pass the examination, but some people are interested to become good doctors. So any question I take up. Then you go to nodular hyperplasia. In contrast, I centrally, as I told you, centrally I go back. I show you this is the central area over here. This is becoming compressing, okay? Centrally, it's situated glands and is more likely to produce urinary obstruction. And that's quite logic. At the same time, it's very, very, understandable that the central area will be blocked and you will have an acute retention of urine. Histologically, the prostate is composed of glands lined by two layers. I'll show you the basal layer and the cuboidal layer, covered by a layer of secretory columnar cells. Now, you've got to understand this. So this is basically the BPH. And people getting more than 45 to 55 years of age, they start developing slowly, but the symptoms usually come around the age of 65 to 75 years of age. When you go to the King Fahd Hospital, you see a lot of cases daily, the daily biopsies, and our famous pathologist, Dr. Wala Burhan, is a specialist in the genitourinary, pathology, and she's doing a lot of prostate biopsies. And if you have a chance, go and see when she's in the King Fahd Hospital. Excellent pathologist. The normal prostate gland weighs 3 to 4 centimeters in diameter. The prostate is enlarged due to prostatic hyperplasia, which appears nodular and becomes from 20 grams to it goes up to 100 grams. Thus, this condition is termed as benign prostatic hyperplasia or nodular prostatic hyperplasia. Keeping in view of this one, here is a benign prostatic hyperplasia. You can see nodular all these areas, but they are not stony hard. When you do a DRE, digital rectal examination, this is a little smooth, but they have lobulations, okay? You can see nodular type. So nodules appear mainly in the lateral lobes. Such enlarged prostate can obstruct the urinary outflow from the bladder and lead to obstructive uropathy. So now this is an MCQ, and this is the thing we are going to ask in the practical. BPH has no relation to the risk of prostate cancer. Please remember, no relation. Somebody having BPH, that means going to prostate cancer? No, no. Prostatic cancer is something different from BPH. Please always remember this point, and this is a thumb rule. And the enlarged prostate gland seen here, the white arrows you can see over here, not only has enlarged lateral lobes, but also has a greatly enlarged the median lobe also that obstruct the prostatic urethra. I told you the central area. This leads to the obstruction, and subsequently due to back pressure, you're understandable there'll be a bladder hypertrophy, as evidenced by the prominent trabeculations. You can see the trabeculations over here. Very clearly you can see of the bladder wall seen here from the mucosal surface. Obstruction and stasis. When the urine is not able to move, what can you expect? You can expect that leads to formation of stones and even the cystitis and back pressure can cause pyelonephritis, all such things which we are discussed in our case. You can see the trabeculation is very clearly over here. You can see the trabeculation that led from the BPH, see on the mucosal surface of the bladder with the hypertrophy. So the stasis of the obstruction predisposed to cystitis and pyelonephritis, causing leads to the bilateral hydroureters and hydronephrosis, and that's quite logical. I told you that's why this particular practical will be al-Hadia and Majjanan and Balash for you, inshallah. Now, this is the same thing. We'll put this slide for you in the examination there on the table or under the microscope. To the left, you can see the microscopic appearance of the normal prostate gland. Can you see over here this area? This particular area. Okay, normal prostatic but on the gland is composed of mixture of glands. You can see this mixture of glands and intervening fibromuscular stroma in equal proportion here at the low power. This is a normal prostate gland. You can see over all the normal prostate gland microscopically. There's no enlargement of the glands, and the stroma is also quite normal. Just imagine this if you have this one. Now here you can see a lot of glands microscopically involving both the and even the stroma, the pinkish area is also hyperplastic as well as the glands as compared to the benign looking glands. Here also benign, but the problem is you have so many glands and they are hypertrophied. Okay, when you see the cut sections through the enlarged prostate from the openings of the hyperplastic prostate, I was just asking my students F13 and F16 that if you do a TURP, transurethral prostatic resection or prostatectomy, you send these samples to us, to the pathologist, such that we might detect prostatic cancer which is healing previously got to follow for the patients. Very, very important. You can see over here the BPH at higher magnification. You can see enlarged prostatic glandular hyperplasia. All these are glandular hyperplasias. Somebody want to become a good pathologist, they are most welcome. And you know, the glands are lined by hyperplastic. See the epithelium which is so hyperplastic. Okay, hyperplastic, projecting the fronds inside. You can see the fronds over inside. You can see this is the fronds. You can see this fronds. These are the fronds, the hyperplastic. And you can see the fibromuscular stroma, black arrows, which is hyperplastic. And this particular thing we'll ask you in the examination, Ishhada. Hada Yusamma corpora amylosia, the red arrows. Okay, you can see the red arrows. You can see red arrows. They are small laminated pink concretions within the glandular lumens, and these are the due to all calcification. In both the epithelium and the stroma, BPH is actually hyperplastic. Okay, we have this particular slides. You can just copy that particular slide, and you can go and try to see the in the Chrome or Google Chrome. Try to expand that one. There's a virtual slide list for prostatic pathology. Dr. Nawal Mohammadi has provided us 3 excellent slides. The slides, inshallah, in the end, if it's possible, I try to open it. Okay, these are the links actually, basically, for the normal prostate, for the BPH and chronic inflammation, and the ductal carcinoma of the prostate. It's very, very important. Now, I just added few diagrams for you. It's very, very important to remember. This is basically a non-obstructive pathology, basically, just to show you what you actually see in the CT scan. Okay. Can you see this one, the overlay? Hello, my students, can you hear me?
Yes.
Yes.
You try to see this diagram. This is a non-obstructive renal calculus. So, you know, we have taken a CT scan with the oral contrast, basically. That's why you're able to see this all this contrast moving in a coronal plane. A non-obstructive hyperdense calculus, you can see the red circle. Very clear, that's the calculus. See the red circle? I'll just try to show you. This one, okay, this one. Okay, this one is present in the left renal pelvis. Now, basically, what is happening is the atherosclerotic calcification. You can see the atherosclerotic calcification. You can see the red arrows, basically, of the abdominal aorta, red overlay. This is basically the abdominal aorta. Okay, and are also seen. So the middle streak artifacts like white arrows. Okay, the middle streak. There's the middle streak. Artifacts between the aorta and the inferior vena cava, the blue overlay, basically, okay, are caused by internal spinal fixator. So you can see over here the kidney dashed lines, and the liver you can see, the stomach you can see over here. This PM is the psoas major muscle, okay, and this is the basically urinary bladder. So this is a non-obstructive renal calculus, okay. We go furthermore, and we see over here the calcium oxide crystals. Okay, we see under the microscope. If people are interested, I can demonstrate if possible in future. if we can just take the urine examination, try to do, and this is basically the overlay. This is like looking like an envelope, right? Photomicrograph of a urine sample, the urine sediment we try to examine over here with intermediate magnification. Multiple envelope shaped crystals can be seen, basically indicated by the yellow overlays throughout the sample. Okay, throughout the sample. These are composed of calcium oxalate crystals and have an octahedral structure. This is basically an octahedral structure. Okay. Keeping in view of this one, we go furthermore. You can see again a very good calculus over here. Not to confuse, you can see in this particular coronal plane. Okay. You can see the same one with the infravena cava and the abdominal aorta. And you can see this particular kidney going for hydronephrosis. So, like that. Okay. Keeping in view of this one, again, you can see in the ultrasound a stone and you can see the shadow over here. This is the overlay. You can see the shadow over here very clearly. You can easily make out basically when you read properly. Okay, and this one also I just wanted to show you. This particular two diagrams. This is an obstructive. You can see over here this area. Okay, see, I just copied this over here. You can see this area again. This is obstructive renal, basically. We call this an excretory ureteral calculus, excretory urography. A calcification, you can see the medial to the lower part of the right kidney in a pre-contrast radiograph. You can see the red overlay is shown in the post-contrast to be an obstructive proximal ureteral calculus. You can see UC means ureteral calculus very clearly. The right kidney is enlarged with persistent enhancement. You can see the right kidney with the enhancement, the green overlay, this one, as compared to this one. See? There is a pelvic collector system in the poor contrast filling on the right ureter region indicated the dashed arrows very clearly. Okay. So the left renal collecting system is normal. You can see this normal area over here. Sorry, this is the normal area as compared to the abnormal area. That's the idea I'm trying to show you. Okay. We go furthermore. I was telling you that if you have an upper vesicle or upper urinary tract obstruction as compared to lower urinary tract obstruction, the symptoms will be, clinical features will be different. Acute obstruction in the upper supravesicle, the renal urinary calculi, hematuria, nausea, oliguria, clinical signs of inflammation. Chronic, of course, signs of hypertension will be there. But lower infravesical urinary tract infection, for example, urinary retention, suprapubic pain, and the mild distension in lower quadrants, palpable bladder. Now, this will cause a bladder obstruction as we have seen in the BPH. Okay, it's very, very important. Okay, we go furthermore. I'm trying to show you over here the normal kidney, grade 1 hydronephrosis. You can see the dilatation of the pelvis, then grade 2, grade 1 dilatation of the callus is more, you can see. Okay, and flattening. Now, this calluses will become flat. Shuf in a flat, okay, flattening. And you can see grade 4 hydronephrosis, the renal atrophy. You can see slowly the renal atrophy occurs and thinning of the cortex occurs. So this is very important to understand. I'm trying to give you some photomicrographic representations such that it becomes a photomicrographic memory for you people. You can see over here the basically you can see the hydronephrosis grade 3, and you can easily make out in this particular area. All these things are expanding. Grade 1, and you can see again having this particular area showing lot of hydronephrosis grade 3 to 4. 3 to 4 will come over here. And in a hydronephrotic patient, severe dilatation of the renal pelvis, calluses, and fornices, the parenchyma is largely compressed over. You can see over here again, very important things actually. Yes. Now this particular diagram, you can see, I'll show you the overlay. Now, can you see over here in this particular, see how this thing has been directed? You can see over here. See this particular area. Okay. As compared, we go to the overlay now. You can see. Now, this chronic ureteral obstruction, the CT abdomen of the pelvis without contrast, coronal plane of a patient with a history of neurogenic bladder, okay, and recurrent urinary infection. So what is happening? The renal calluses, pelvis, and ureters are dilated. You can see the green overlay, all are dilated with normally concave, cup-shaped and renal calluses. You can see over there. Thinning of the renal parenchyma, examples they are indicated by the, you can see these white areas. White dashed lines on the parenchymal edge very clearly. Okay. Now, this suggests the dilatation is a chronic rather than an acute. So, marked thinning of the bladder wall and the red area you can see is likely responsible for the chronic ureteral obstruction, basically. Now, this is the idea, you got to know it. Okay, then you go further more to understand how the second stage of hydronephrosis develops. You can see the pelvic calyceal system being dilated. Again, more advanced, 2 and 3. See the calyces being expanded more, and you can see even the flattening now at that stage. You can see the flattening of the calyces. That's why I wanted to show you. Okay, you can see more advanced. All this is so dilated. Okay, that's the idea. So we come to the last of our slides, and this is basically the zones of the prostate, which I already showed you before. And here you can see, and just to know the different zones, the zones of the prostate are very important. There are three main glandular zones of the prostate. I showed you the peripheral zone, the largest zone, 75% of the glandular area. You can see the peripheral zone. You can see the number 6 over there. 75% of the glandular tissue of the prostate and adenocarcinomas develop in the peripheral zone. I told you, peripheral zone lies in the inferior in the posterior aspects of the prostate gland and is readily palpable in the digital rectal examination. So the central zone number 5, you can see the reddish area, lies posterior to the transition zone and surrounds the ejaculatory duct. It contains 20% of the glandular tissue, basically. Okay, and it's an uncommon site of cancer. The transition zone, basically, you can number 3, is a part of the prostate that surrounds the urethra. It contains 5% or less than 5% of the glandular tissue, and there's the region of the BPH. That's why I wanted to reveal this particular area for you. Very important. And here you can find very, very important thing. So this particular, you can see this enlarge the median zone of the prostate. Okay. Now here you can see over here. This is the prostate, and this is the prostatic urethra going on. Very clearly see. I just wanted to focus your attention. You can see over here. This is basically the benign prostatic hypertrophy with the corpora amylacea. You can see over here very clearly, and see the gland which are, and you can see the fornices coming up inside very clearly. And here, basically, this is only for your more understanding. This is the multicentric MRI prostate cancer. They try to do it. MRI, prostate gland multiparametric. This is a T2 weighted MRI. Okay. Dynamic contrast enhanced axial plane patient with the prostatic adenocarcinoma. So the prostate gland, basically, I'll go over here. You can see this one. You can see I'm trying to show you the overlay. The prostate gland, green overlay, is enlarged, elevates the bladder floor. The red overlay, it's elevating the bladder floor, and a hypo-intense lesion arrow is seen in the right anterior transition zone in the axial T2 area. So this hyper-intense on the DW1 and the hypo-intense in the corresponding ADC cap bottom, you can see the bottom area. It shows marked contrast enhancement, and this particular thing at the same time you can see a lot of enhancement by giving a radioisotope indicate that this is the prostatic cancer. Okay, that's the idea. This is again a back-to-back arrangement. You can see the glands back-to-back arrangement, back-to-back arrangement. Very clearly, this is prostatic cancer. Okay. Now, some questions are there for you when you ask the patient. There's incomplete emptying. Try to understand this one. The amount of frequency the patient going to the toilet, intermittency, urgency, weak stream, straining, nocturia. If you were to spend the rest of your life with this, with your urinary condition, are you ready? Nobody will say, I'm ready. So that's the idea we got to ask them. And this is the last slide for you. This is only for the theoretical understanding. That day, our students were discussing serum PSA levels, okay? Prostate specific antigen. Indication not routinely required. Now, this is very important, okay? Consider the prostate cancer is suspected with a life expectancy of more than 10 years who are eligible for prostate cancer treatment. You got to have a follow-up, right? Follow-up, very, very important. Okay, now you can see, go read the prostate cancer screening program. Okay, to aid the selection of the pharmacotherapy for the BPH. Findings in the PSA is more than 1.5 suggest enlarged prostate. MCQ in SMLE. Okay, total prostate less than more than 4 nanograms, increased likelihood of cancer. MCQ. in SMLE. Okay. Now, free PSA levels and free PSA over total PSA ratio got to calculate. Now, if the ratio is more, free PSA usually seen in BPH. And if the free PSA level here, the ratio is less, suggests prostatic cancer. You got to calculate. We have no time to calculate now. If I give you a problem when we solve the MCQs, if possible, then I can show you. We have a lot of MCQs on this calculation. But that lot come in the examination of SMLE, so I'm not interested for you. So serum PSA levels are not measured routinely in the enlargement of the prostate. So very, very important for this one. So low PSA level does not rule out prostate cancer. These are the MCQs which is going to come up. Now this calculation, inshallah, actually I want to start some of the nutrition metabolism classes for the Indian students. Only MCQs, only MCQs. So if people want to join, I'll just post it and give it to our F3, F13 and F16 people. So all the students can join. It'll be like 1 hour, almost like 5 days a week. And you'll get a lot of knowledge on nutrition metabolism. I'll start the GIT, then I'll go to the neurology, then I'll go to the endocrinology, like that. We try to finish in 1 year. Some it will be like 1,000 MCQs. It will be very useful for you if you want to join. It's all free and it's nothing to do with your examination. It's only to develop more knowledge and try to see that in future you'll write the SMLE examination better. So with this, I end up over here. I'll try to give this PowerPoint to Hadil. Inshallah, she can share with you. Any questions? I'll take up. Hello, can you hear me?
Yes, doctor.
Any questions I take up? Otherwise, I think it's all clear. As far as examination is concerned, it's very easy for you. Just try to read that particular which she has given to you, and inshallah it will be very easy. We'll try to just discard this and just wait on if I can come to this particular area. How can I shift to that slides where Dr. Nawal has given? I wanted to show you that one. How can I shift there? Well, I don't know. Do I do stop sharing, Yane? We finished it. It's only additional. Shall I do stop
The
sharing?
link?
I
Do you
just
mean the
want
link
to.
in the slides?
Huh?
Do you mean the link in the slides?
Yeah, link in the slides. Yes.
You could
The
just
three links.
copy it and paste it in the browser.
Okay. 1 second. Right. Can you see it now?
Yes, we can see it.
Yes.
Okay. Right. Okay. What do you see over here? Anybody tell?
Glandular tissue.
Okay. Glandular tissue. What is this one now? Tell me. Very easy. Spotter. I go back. Okay. Now you can see. This is basically a normal prostate gland. You can see over here the gland and the stroma looking very normal. Okay, normal. When you go to the prostatic hyperplasia, you can see this one. Lot of glands being proliferating. Glandular hyperplasia with, of course, you can see lot of intervening fibromuscular hyperplasia, and you can see the fronds. You can see the fronds over here very clearly. They're being, as compared to this one. This I wanted to ask you. What is this one? Now tell me. This one. There is no stroma, okay? Only glands. You can see back-to-back arrangement totally, and you can see hyperchromatic, very dark-colored pleomorphic cells lining the prostatic epithelium. And this is cancer. And at the low power, we diagnose it, okay? At the low power, this is cancer. This is basically the benign prostatic hyperplasia, and this is the normal prostate gland. Okay, this cancer. That's all. When you see a cancer, you have back-to-back arrangement of the cells. No stroma. See, very dark colored, hyperchromatic, pleomorphic nuclei, and the stroma goes little. And here in the corner, you can find stroma. But here in the prostatic area, we have a cancer, the bluish area. Yes. But you go to here, you can see the only BPH with stroma and the glandular enlargement, all hyperplastic glands and the stroma. But here you can see very normal looking stroma and the gland. See very clearly. Understand?
Yes.
Yeah. Okay. If you people can ask any questions, if there is a MCQ thing, I'm going to start. I did not till now selected the date. Inshallah, I'll let you know. You people can join. It's something like a additional thing, and even I took the permission from Dr. Syed Nazar, and it's not for your Taiba examination. It'll be for understanding the subject more. It'll be more detailed. Like we are going to calculate the PSA, and we are going to have a clinical scenarios of all those such things. So it'll be more interesting. Jazakumullah khair. Any questions I'll take up before I close?
Doctor, I have a question.
Yeah.
So we do the digital record examination to exclude if there was an adenocarcinoma in the peripheral zone.
Yes, exactly. You just wear the glove, take the consent of the patient, and tell him that I'm putting my fingers into your rectum through the anus, and it might pain you, little one, but no problem. I'll just take it. Then the patient says, okay, with your gloves, try to examine the prostate, the peripheral zone with your fingers. Most of the time, it is smooth. If it is enlarged, you can see it is enlarged, but it's smooth in the case of BPH. But if it becomes a little rough and hard, think of this is you're dealing with a malignancy, that is the prostate cancer. Yeah, you can easily make it out. Okay, I was telling my students in the first session that it can cause little disturbance to the patient. You can see that the little prostatic fluid can ejaculate from the penis, and you have to inform them because they might sue us. So we have to be very careful, and we have to have a medical ethics in control. So we need a lot of respect to the patient and take a consent. Any questions more?
Yes, doctor.
Yeah, sure.
In the extra slide, you show us a CT scan, which the enlargement in the ureter is under the stone. Why it's under the stone? I think it's a slide in 14 shape, something like that.
Which one? This one? This one you're telling?
No, 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 it's not.
You mean this
Yes,
enlargement?
yes, yes,
This is an
yes.
artifact. This is an artifact. This is an artifact. Yeah, it looks enlarged. See, this is basically a psoas muscle. It's not enlargement. Here the enlargement. You can see.
Okay.
Understand?
Okay.
Yeah.
Yes, yes, yes.
Any
I
more
think
questions? Yeah, no problem. It's quite understandable. Your question is valid, and yeah, this is psoas muscle. Yeah. Anybody want to ask anything more? They try to see this. It's very, very good. Basically, nowadays we are dealing with the virtual. I sit over here. I try to report skin pathology slides from all over the world. It's free, of course. If there is something like a difficult case, so we do it like that. So we call it telepathology. It's quite understandable. So this particular the PDF Hadil will give you. That's all which is required for the examination. Okay. If you want this slide, this particular thing, I'll give you. No problem. I'll hand over to Hadil and you can share it with each other. Any more questions before I close? Okay. Thank you so much. I'll close now. Okay. Jazakumullah khair.
Thank you, Doctor.
Jazakumullah khair. Rabbana ainak.